Dear urologists, good evening one and all. Today in the pure urology topic is interesting, not commonly discussed. I don't think I have discussed this before, Peyronie's disease. As you all know, there is not much medical management to my knowledge, though I am not very experienced in this field. I feel that in significant Peyronie's disease with complaints by the patient, surgical treatment is the best treatment. To discuss about that, today we have Dr. Pramod Krishnappa, and I will introduce him very wisely and very early age. He has chosen the subspecialty as the main specialty for his career, working in Bangalore. He is MBBS, MS, DNB, CHM, Edinburgh, and FECSM. He is consultant uro-andrologist at NU Hospitals, which is well-known hospitals in Bangalore, a group of hospitals, in fact, India. European Society for Sexual Medicine Penile Implant Fellowship in Madrid, Spain. That's what we were discussing. This is going to be the future after the MCH Urology or DNB Urology, Dr. NB Urology. If you go for 6 months, 1 year, either one subject or 2 subjects fellowship, and then decide which you suit for, will have a lot of value. He is one of the example. European Urology Scholarship Program in Penile Reconstruction in Belgrade. Visiting Fellow Male Infertility at the University of Illinois at Chicago, USA. MIUC Travel Fellowship Oncosexology, Oncofertility, MSKCC, New York, USA. Great. Panel member, Male Sexual Dysfunction and Infertility, International Consultation on Sexual Medicine, Guidelines 2024. Male Infertility Urology Society of India, Guidelines 2023. So it is really pleasure that an youngster is focused and went to fellowships with his own money probably and struggled and ultimately settled as uroandrologist. Let us listen from the specialist of how to manage Peyronie's disease right from the basics. Thank you, Pramod, for accepting, and over to you.
Yeah, so thank you very much, sir, for this invitation. I'm very happy to accept this and share my experience and also the evidence what is there currently in the Peyronie's disease. So let me share my slides. Yeah, I hope the slides are visible.
Visible, clear.
Okay. Yeah. So thank you very much again, sir, for the kind introduction that you gave in. We'll also discuss about the subspecialty andrology. I've put up one slide at the end. So let's, for now, focus on the Peyronie's disease. I have divided this into under 4 headings. And like Dr. Chandramohan sir said, surgical management is the only possible or the only practical solution that we have for our patients in India. I will discuss why the non-surgical methods are not so practical in India. We'll come to that. So briefly, I will touch upon all these topics. And I have around 5 publications on Peyronie's disease. If you see, I'm either the first author or the second author in all these papers. So what I speak is with evidence and with experience. So few slides about the introduction. It's an underdiagnosed condition. Prevalence is around 0.4 to 20%. And again, very common in diabetics. Usually we see in around 50 to 60 years of age, but sometimes we do see in young patients too. And the most important message that I would tell is every penile curvature is not Peyronie's disease. Okay, so this was the recent the diagram or the paper that was published just 4-5 months back, wherein it explains the penile curvature in a very nice way. So the penile curvature, it can either be a Peyronie's disease or it could be a congenital penile curvature, an adult coming at an maybe around 25-30 years of age. He knew that he had curvature, but he's coming now because he wants to get married now or so on. Or maybe having a girlfriend now who has commented about his penis. So curvature could be Peyronie's, congenital, or a trauma-induced. See, in Peyronie's, the trauma component is mainly the micro trauma, whereas there is something called trauma-induced penile curvature too. And there's a new concept that has come up which is called as the maturational penile curvature, wherein this curvature usually starts by around puberty or so, and it is different from congenital. Like I said, this was a recent classification that was done by the Landon Trust and his colleagues, published just a few months back, September 2024, a new classification system for penile curvature. Again, I will not go into the details of all this. So in short, they have done a PTNM staging wherein P means is there a Peyronie's disease component or not? T means is there a trauma component? N means it's a non-Peyronie's, which like in a congenital penile curvature, it will be considered as C. And M means whether it is a stable disease or an active disease. So for example, if it's a case of stable classical Peyronie's disease with no any prior trauma, so this will be classified as PCL. CL means classical. T0 means there's no trauma. N0 means, so there is a Peyronie's disease component. There is no non-PD component. M0 means it's a stable. So that's how it's a recent classification that's being described now. And so the etiology is, as of all of us know, it's unknown. The most widely accepted hypotheses are repetitive microtrauma, which leads to abnormal wound healing and abnormal remodeling of the connective tissue, leading to a fibrotic plaque. And the genetic basis, a lot of studies are going on, but as of now, it's poorly understood. And again, there are a lot of associated factors. We'll not go into the details of this. Yeah, this is something very important. We always should be aware of the two phases. One is the acute phase and then the chronic phase, because any surgery or any intervention that you can do only in this chronic stable phase. So the first phase, which is the acute phase, it may last from 3 months to 18 months. So you may have a patient who is coming even after 1 year of this Peyronie still complaining of pain. So which means he might still be in an acute inflammatory phase. So you need to give some time for him to settle down. So the acute phase may go even up to 18 months, and during which he will have a painful erection, or the nodules or the curvature may start to appear. Whereas in the chronic or the stable phase, usually the plaques are set in and it may or may not calcify, and usually the disease is stabilized with no further worsening of the curvature. So in the diagnosis, so what are the important things? So one is that stretched penile length is important before you put a knife on these patients, because some patients may be unhappy saying that their penis was of a normal length. After surgery, this has reduced in size and so on. So one of the most important document that you should make is the stretched penile length, measure it and just document it. And again, assessment of curvature is very important before you plan any treatment or surgery. There are two ways to assess the curvature. One is if the patient has good erections or decent erections, you can tell him, boss, you go home, when you're comfortable, just masturbate and take a erect penile selfie. Two views. One is from above down and the second is lateral view. So that it will give you a rough idea of how much is the curvature. Second is if the patient says, doc, I am not getting any erection, so I cannot take an erect penile selfie. So what next is, so you can give an intracavernosal injection, make sure that you're not pricking the plaque because it will again be very painful. So avoid the plaque site and then give the intracavernosal injection, with which most of the time you're able to measure the curvature. If none of these work, then of course, intraoperatively, you need to do a modified Gitti's test before you place the incision. So third is the ultrasound. Yeah, penile Dopplers, you can get it done to document the plaque size and the location, and also to document the flows. CT and MRI, there is no role in Peyronie's disease. So many of these patients, they get scared thinking that this is some cancer. So that is something that we need to assure them that this is not cancer. It is something, abnormal wound healing or abnormal collagen formation, which may require treatment. So there's no role of CT or MRI in Peyronie's disease. Before we start any treatment, we need to understand the natural history of Peyronie's disease. So I was very privileged to do a 1-month fellowship, which was awarded through the ASU. This was 2 years back. So I spent time with John Mulal at the MSKCC. So he published the natural history way back, I think in 2006, where he studied 246 patients who received no treatment. He just wanted to see what happens to all these 246 patients. And the mean follow-up was he followed up around 18 plus or minus 7 months. And the findings were, at this follow-up time, all patients had some improvement in the pain with no intervention. And around 89% of the patients had complete resolution of the pain. Again, remember that this is without any treatment. And also the curvature, 12% of the patients, they had spontaneous improvement in their curvatures, 40% remained stable. And of course, the 48 remaining patients, their curvature worsened. So this is very important, because if some study tells you that there was 10% improvement in the curvature, we do not know whether that was due to this treatment or whether it was just the natural history of that Peyronie's disease. So this is an important slide which all of you should know. So any management that you decide in Peyronie's disease, the goals should be, one is for the pain relief in the acute phase, which is the only thing that we can do in the acute phase, the pain relief. Other things being to give him a satisfactory sexual intercourse by correcting the curvatures and by improving the erectile functions. And like I said, to allay the fear of malignancy, saying that it's not a malignant problem, it's something called as a Peyronie's disease. So what are the non-surgical options we have? So all these are mentioned in all the guidelines in the textbooks: oral tablets, topical creams, intralesional injections, penile traction devices, vacuum erection devices, and the low-intensity shockwave treatments. So all the guidelines have clearly told that do not offer any oral treatment. And in fact, vitamin E is still being prescribed by many of us, many urologists. But yes, I can understand that you need to give something as a placebo. It may help to some extent, but physiologically also, there is none of these medications have any role. In fact, the guidelines have clearly told do not offer any of these. But if you really want to give them as a placebo, make sure that you are aware of all these side effects. I think the colchicine is very commonly given. So tell them that they may have a diarrhea or so. So you can see if you can taper the dosage or give the medicines in a tapering dose. And so the current trend is in acute phase of Peyronie's disease is to give PDE5 inhibitors. In fact, there are many papers again stating that you can give tadalafil daily or sildenafil daily for 3 to 6 months. And the way these PDE5 inhibitors help in acute phase of Peyronie's disease, even if the erections are good. So the theories that have been explained are, it helps in septal scar remodeling. It has been shown both in animal and the human studies. And also these PDE5 inhibitors, they have these antifibrotic effects also. So the European Society for Sexual Medicine, ESSM, they conducted a survey during their annual congress. And what most the doctors who attended the congress told that around 57% of these doctors said that they give daily 5 mg tadalafil as a medical therapy in acute phase of Peyronie's disease. In fact, that is what I also do. So I just give them 5 mg tadalafil daily for 3 months, irrespective of their erectile function. Topical agents, again, all these are described, but none of them work because the Peyronie's plaque is a tough structure. None of these gels which you apply on the skin will not be able to penetrate and actually cause any effect on that plaque. So no topical gels work. And intralesional injections, they were very rampantly being used in the past. In fact, verapamil was first revolutionized by the Levine from the Chicago. He himself is not using the verapamil anymore. The other options being interferon and the collagenase injections. Interferon again is almost stopped. Collagenase, yes, mostly the Americans are using it. And if you see this trend, like I said, collagenase, yes, more and more of this being used in the US. Interferon has almost been stopped. Verapamil, yes, some of the centers are continuing to use it. And so during my fellowship in the Spain, Tuesdays, we used to have this Peyronie's clinic. wherein Martinez Salamanca, the Tuesdays, we used to give a lot of these collagenase injections. Again, the main issue with this is it's very expensive. So let's not discuss too much about these intralesional injections because none of our patients will be able to afford them. For example, if you take a course of 6 cycles of these injection, it may cost roughly around 25 to 30 lakh rupees, a full course of collagenase injection, which is, I don't think anybody, most Indians will not be able to afford this. So let's not discuss too much about this. In fact, I did my fellowship in 2018. The very next year, the collagenase was withdrawn from the European market. So it was not available for nearly 3-4 years. Only recently, some generic forms have been made available. So what basically happened is that there is a specific technique, the way you should inject these collagenase injection. So it is basically a medical knife. Collagenase is a medical knife. You need to inject it at the maximal curvature and not target the plaque. Basically, see, if you're giving a verapamil injection, you inject it into the plaque. Whereas collagenase, you inject at the maximal curvature. Whether plaque is there at that site or not, it doesn't matter. You basically inject at the maximum curvature. Basically, this acts like a medical knife. So people used to inject it into the plaque, and what had happened is people started developing spontaneous penile fractures because of this rampant use of this collagenase injection. So I think that was one of the main reasons why they withdrew from so many European centers. And as of now, Xiapex is available only in the US, but yes, since last 1 year, some of the generic forms are available in the Europe. And like I said, expensive, very expensive is the reason why most centers do not use collagenase.
Is it available in India, Pramod?
No, we need to import it, sir. Again,
roughly cost 2-3 lakhs, something like that.
So no, sir, I told you just now. So 6 injections will cost around 20-25 lakhs.
Okay.
Yeah. If someone of you still want to inject verapamil, this is the classical technique described by Levine. I don't do any intralesional injections. If somebody still want to do it, verapamil, because there is some data. And like I said, Lawrence Levine started verapamil injection. He himself is not doing verapamil injections anymore. He is using collagenase. So basically, you can take 10 mg of verapamil, dilute with 10 cc normal saline, and then you need to use you can take a 25 gauge needle and use a Urology syringe and give a penile block and then inject this 10 ml in and out of the plaque. And again, if the plaque is very much calcified hard, this entire maneuver may be unsuccessful. And yeah, so this set of injections has to be administered at an interval of 2 weeks for around 12 total treatment sessions.
All these should be done in chronic phase, not in acute phase.
Yes, sir. So acute phase.
Somebody asked a question, how will you know that acute phase is over? By absence of the pain, 1 month like that?
Yeah, mainly the pain. And if somebody is developing curvatures, he will say that since last 3-4 months, there is no any change in my curvature. That is one thing, but mostly it is pain. So the pain again is something difficult to assess. When you press any plaque little hard, it will pain for everybody. So it is pain irrelevant to the erection if somebody is still getting pain. So that is when we should consider the patient is still in the acute phase.
Okay.
Okay, so now moving on to the penile traction therapy. Again, this is also something which we cannot afford or we cannot offer this to our patients because all the penile traction devices, the best ones are not available in India. I will describe about that. Again, this was one of the papers which we published just 2 years back about the various penile modeling techniques. If you see in this, in this review article which we did, around 57% of the papers mainly dealt about the penile traction therapy. This is fast catching up in Western countries, but again, because of the lack of availability of these good traction devices, we are not able to offer this in India. And so this was a study done from the Mayo. So they basically assessed what is the preference pattern of these Peyronie's disease patients. So at baseline, when all the options were given, 45% of the patients, they chose to receive a penile traction therapy as the first treatment in Peyronie's disease. And after 3 months also, in fact, many patients, they were quite happy with the traction therapy. And you see here, only 2% of these Peyronie's disease patients actually are willing to undergo surgery. I think you have also experienced the same in your practice, that how much ever we try to convince the patients, many patients, they are scared to undergo any surgery on the penis. And yeah, so that's the reality. Only 2% of these Peyronie's disease patients turn up for surgery. And I know the Mahakumbh is still going on. Chandramohan sir, did you see any of this there? No, yeah. So this is not penile. This is not the way the penile traction therapy is done. Yeah. So this is an unregulated traction therapy. So there are various specifics of how a penile traction therapy should be applied. So these penile traction devices are even abused or used by even the porn stars. If you see there, even the porn stars in the US, they have a dedicated protocol. They follow a certain lifestyle wherein they concentrate on all these things to develop hardness, good hardness in the penis, and then they follow all these for the stamina. And for the penile size maintenance, they also have something called as these extending devices, which is basically the penile traction devices. So these are very rampantly used in the porn industry, thinking that they think that this is gonna enlarge their penis, but mind you that these penile traction devices are not to enlarge the penis, because these penile traction devices work only on this abnormal plaque tissue. On the normal tunica albuginea, these penile traction devices do not have any role. So they should not be propagated or marketed as penile enlargement devices. But sadly, it is easy to sell these devices in this name. If you brand them as penile enlargement devices, many of them, they fall for these gimmicks, and then they tend to use these devices. Okay, so there are various penile traction devices. So the PiniMaster Pro is the one we published in the British Journal of Urology in 2018. We published this when I was doing my fellowship there. So basically, it comes with a nice box, and I'm not trying to propaganda or market this, because anyway, it's not available in India. And in fact, I had 2 patients who came to me saying that, doc, we read your article and we ordered it in India. Means through an American website, they ordered it, and then it came to the Bangalore airport and it was stuck there. The customs did not release it, they stating that this is a sex toy. They came to me asking the doctor, can you please give a letter saying that this is a medical device and so on. I still gave a letter stating my study and all that. Still, it didn't get released. So many of these devices are considered as sex toys and may get stuck in the customs in the airport. So in fact, both these patients, they could not get these released. So if somebody is going to the US or Europe, then they can buy this and then they come here. But if you order it online, it will never reach you in India. So again, there are different concepts in penile traction devices. So see, basically the aim is you may not get an exactly straight penis. So if somebody had this around 80-90 degree curvature, when you use penile traction devices, so yes, the curvature may get corrected to this extent. He may have a residual 20-30 degree curvature, but yes, with this penis on the right side, he may be able to penetrate and have a satisfactory sexual intercourse. The only problem with all these penile traction devices is that they have to be worn only during the daytime, not at night, because the glans numbness can happen and we do not know what can happen to the circulation. So the advice is to wear these devices only when you are awake, and they have to be worn for at least on an average of around 3 to 6 hours, which practically may be bothersome or difficult for many patients, and they have to wear this for nearly 6 months. And when they stop it, yes, the recurrence may happen over a period of 1 to 2 years. But yes, to some extent, it gives relief in the curvature. The curvature correction may happen by around 30 degrees on an average. So recently, in the sense 2 years back, the Mayo Clinic team, they released a newer, they call it as a second generation penile traction device by the name of Restorex, wherein this device can be worn only for 30 minutes, as against 4 to 6 hours with the other penile traction devices. So again, this is also not available in India. In fact, it is not even available in the Europe, only available in the US. Again, there is a mechanism that is being described on how these penile traction devices help to correct the curvature by a mechanism called mechanotransduction. I will not go into the details of this. I know most of you will be wanting to know more of the surgical management. So the final conclusion on these traction devices is that it is still limited, and it is still an evolving option. And again, all the EAU, ICSM, AUA says that it is an weak recommendation or an insufficient evidence to prescribe these penile traction devices. In fact, this is the only company which is there in India. And in fact, they approached me stating that, Doc, do you want to take the distribution or partnership or something in India? They offered me, but I said, no, boss, I have a lot of other things to do. So I rejected this. So if any of you want to order, you can just see the website that I have written there, and you can order if you want this. And again, see, what the device that you're seeing is the Andro extender, basically, which is not being used in any parts of the country. So I think I don't know whether it is just being dumped in India so that here people can use it, the ones which have not been used elsewhere. So the cost is around 11,000 to 15,000 rupees, the cost of these penile traction devices. But the thing is, the patient has to be compliant and use them for at least 6 months, 4 to 6 months. Only then they will see improvement. Vacuum devices, again, in the systematic review article, we mentioned about the use of vacuum devices. Again, there were only 2 studies in all these years, and again, the evidence is weak. Shockwave therapy is fast catching up. The cost of a good shockwave treatment is around, shockwave therapy machine is around 25 to 35 lakhs, depending on how much you can bargain with these shockwave companies. I do not have this shockwave therapy machine. And basically a focal treatment is given at multiple places on the plaques. Again, what the guideline says that it helps in the remodeling of the plaque, improvement in the resorption of the calcification, and so on. The guidelines say that it may be offered to treat the pain, but it does not improve the curvature, the shockwave. But if you see the natural history of Peyronie's disease, the pain will anyway go away in nearly 88% of the patients. So by applying this shockwave, whether is this shockwave helping to relieve the pain or it's a natural history of Peyronie's without any treatment, we do not know. So in fact, the AUA guidelines, the last guidelines on Peyronie's disease is way back in 2015. They have not updated it yet. And like I said, again, this is also still considered investigational. People have combined various methods, like they combined with tablets, with intralesional injections. They have combined collagenase injections with vacuum therapies. Again, a lot of this is being tried. Ultimately, this survey basically said that both and the patients, both are unhappy at the available treatment options for Peyronie's disease at the moment. Even the patients are not happy, even the doctors are also not happy, because many of these things are not available or not practical. So for our domain in India, surgical option is the main treatment that we have to offer for our Peyronie's disease patients. And most important is that don't operate them in the acute phase. So what the guidelines state is that the disease has to be stable for at least 3 months, which means, I know it's not easy to make this decision sometimes. If the patient says that, doc, since almost 6 months, my penis has remained in the same curvature, it has not worsened or so, then, and if the pain is not significant or absent, that is the time then you can decide about the planning any surgical interventions. The simple rule is less than 30-degree curvatures, most men will be able to manage intercourse, may not require any surgical interventions. If it is 30 to 60 degree, you can plan plication. If it is more than 60 degree, you will require a plaque incision grafting. And along with the curvature, if his erection is not responding to any of the oral medications, then you can combine a penile implant surgery along with the curvature correction surgery. So the goal is a functionally straight penis. You may not be able to achieve a exactly straight penis. So even if the residual curvature of 20, 30 degree, is still acceptable. And yeah, so before you start any surgical intervention, I told you that you need to be aware of what is the degree of curvature. I had mentioned it in the physical examination. Either you can ask for a penile erect selfie of the patient. He himself can take it at home. If he's not able to do it, second is you can do an intracavernosal injection in the OPD, check the curvature. If still you're unable to find out the curvature, then intra-op, before you put any incision, please do the modified Gitti's test. So, yeah. So if you see here, the original Gitti's test, if you see the description of the original Gitti's test, he used to apply the tourniquet at the base, and he used to put this needle not in the glans, he used to put it into the shaft of the penis. So this is modified, wherein I never apply any tourniquet. I use a 60 ml syringe. It's not seen in the picture. I use a 60 ml syringe, and I think this is around 18 gauge scalp vein needle or the butterfly needle. And I put it through the glands. Through the glands, I enter into the corpora cavernosa. So this is the way I do the modified Gitti's test. And yeah, when you see such curvatures, yes, many patients are unhappy. It's almost a 80 or a 90-degree curvature, which obviously requires surgical intervention if he wants to be sexually active. Again, there are different types. Again, in surgical methods, you have plication, plaque incision, grafting, penile implants, and so on. So plication, there are many methods described. So if you see, the next bit is you elliptically excise a part of the tunica albuginea, and then you plicate it. Other one is a simple plication, which I very commonly do it, which is also called as a raffling. You take multiple sutures and then running suture, and then you tie it. This is how it appears. Or there is something called as a Hennicke-Mikulicz technique, which is a Yashia technique. You make a vertical incision and then you close it transversely. So these are the common steps that we do. So plication, if you see here, I have already taken the plication sutures here. And of course, this was a severe curvature, so I had to elevate the neurovascular bundle, which is one of the most critical steps. And again, neurovascular bundle elevation is not required for all plication surgeries. It depends on where the curvature is. If the curvature is ventral, then you have to place these multiple sutures dorsally. So you have to elevate the neurovascular bundle. Whereas if it's a lateral curvature, suppose the penis is bent to the right side, you can just place sutures on the left lateral side, and then you will be able to get away with the curvature correction, even without elevating the neurovascular bundle. So this is how it looks after the application. So what I do as a simple plication, it's a raffling technique. And yeah, so of course the raffling technique, so most penises become straight. And even if there is 5, 10 or 20-degree curvature, residual curvature, don't worry. Most patients are quite okay as long as you have explained this before the surgery. This is the Yashia technique. So you make a vertical incision, and then you basically take the stay sutures and then you close it horizontally. Again, this have to be done at multiple places depending on how the curvature is, whether it's a uniplanar curvature or whether it is a multiplanar curvature. Depending on that, you need to place these incisions at multiple places on the tunica. And again, lateral curvatures are the most easier to treat this, even without elevating the neurovascular bundle. It's quite easy to do it. So here, see, if you see here, I have put the needle into the shaft of the penis. But again, I never use the tourniquet in any patients to check the curvature, because if you put a tourniquet, sometimes the curvatures get masked. So either you can put it through the shaft or you can put it through the glans, and then you need not apply the tourniquet, but you need to use a 60 ml syringe and put a little extra pressure so that you can notice the curvatures. Again, neurovascular bundle elevation is one of the most critical steps. So this is the glans and this is the urethra. So the common technique is to put a paraurethral incision first, and then you need to elevate this neurovascular bundle. Take time. Do not be in a hurry when you're elevating the neurovascular bundle, because it's a very critical step. Otherwise, you can end up with a glans necrosis sometimes. So take time, and then you elevate the neurovascular bundle. So go from one side, any side, either right or left, paraurethral, go dissect on one side, and then you can sometimes elevate. You can even reach to the opposite side through the same approach. If you feel difficult to reach the opposite side, only then you can again put an opposite side paraurethral incision and then dissect it fully. I usually start on one side. 80% of the time, I am able to complete through one approach itself instead of putting two paraurethral incisions. Okay. So plication, please don't assume it's a simple procedure. You need to explain all of these. Again, I mainly concentrate on the ones which are highlighted in yellow. I tell them that, boss, you may have a recurrence of a curvature. I will put the strongest sutures, but you still, if you get a hard, rigid erection, sometimes these sutures may give way, and that recurrence is around 0 to 20%. I always use a PDS suture, depending on how big the penis is or how thick the tunica is. I decide on the table, either a 40, 30, or 20. I decide it on the table depending on the thickness of the tunica albuginea. And I mostly use PDS. Very rarely I use a proline suture. Maybe I complete with the PDS and I feel that it's a very significant, and I feel it's a very significant curvature. There is a high chance of recurrence. Then maybe one or two proline sutures I may just take at the end. But mostly I use a PDS suture. So I explain about the recurrence curvature, and I tell that whenever you get an erection, at least for the initial 2-3 months, you will have a painful erection because all these years or the months your penis was bent, and now that we have made it straight, so you will have some pain because the sutures may give you some pain. So you will have painful erection, which will usually subside by around 3 months' time. And also another important thing is that you will feel all these sutures. You may do a not burying technique, but whatever you do, ultimately some of these sutures will pop out, and then that many of these sutures are palpable, and it's nearly 50 to 100% if you use a non-absorbable. PDS is a delayed absorbable. Still, that's why I said up to 3 months, they will feel these palpable knots. These are the three things which I commonly tell. I never discuss about the loss of penile length, which I feel practically may not be that important, but people who have read about all this on the internet, if they ask me, only then I will talk about the subjective or the objective loss of penile length. Because this minimal loss of penile length actually causing a problem in sex is just 5 to 11%. Yeah. So three things: palpable sutures, painful erection, and recurrence. Please explain before you do application. So moving on to the grafts. Again, this is again an article which we wrote. So there are different types of grafts. Commonly used ones are the buccal mucosa. Pericardial graft is the one I use. I think most Indians use the pericardial grafts. Easily available if you are working in a multi-specialty hospital. Just speak to your neurosurgeon friends or the cardiothoracic friends. They will very commonly use this pericardial or the SIS grafts. SIS is submucosal intestinal grafts. Very commonly. So in the US, people use mostly SIS or the pericardial grafts. And then in the Europe, they use something called as a tacocele graft. So this is a tacocele graft. Again, I took this picture during my fellowship. So tacocele grafts are very commonly used in pelvic surgeries when it's extensively bleeding. To pack the bleeding, they put these grafts in the pelvic region. So that same graft, which has the antithrombin activity, the thrombin activity. So you incise the plaque where the curvature is the maximum. And then on this plaque, you just place the tacocele. So for the tacocele, you don't have to fix it. Just keep it and close the skin. That's it. It will get stuck on its own. But the only problem is that with the tacocele graft, you will not be able to assess the curvature after the grafting. So anyway, let's not discuss too much about tacocele because it's not available in India. In India, previously used to get this biodesign graft, which is an porcine SIS graft from the Cook. Currently, it's not available. What we have is the Cinco graft from the Chennai. It's a made in India product. It's a bovine pericardial graft. I think the cost is around, it comes in 4 different sizes. What we need is around 4 by 4 centimeter graft, which costs around, I think around 20,000 rupees. The MRP is around 15,000 rupees. Sorry, the hospital price is around 15,000 rupees. MRP is around 20,000. So it's easily available in India. So I use this pericardial bovine graft. Again, if somebody is very concerned about the religion and so on, so this is a bovine one. So sometimes it's a trick that whether you want to reveal these specific details about the graft or not, you decide. See, porcine, again, if you porcine grafts, if you use it in a Muslim patient, you never know, you may get into trouble. And if you use a bovine graft in a Hindu patient, you never know if it's a religious person. If he gets to know, he might create a problem. So just let this thought be in your back of your mind before you use these grafts. And so post grafting, again, you just put a graft and don't assume that things will be fine. If you're doing a grafting procedure, just the grafting, plaque incision grafting without any simultaneous penile prosthesis, you need to follow any of these penile rehabilitation protocols, which means that either you need to put a penile splint. I will show you what is penile splint in the next slide. Or you need to tell the patient so that he uses the vacuum device for nearly 2 to 3 months time to prevent the graft contracture or the recurrence of the curvature, or penile traction device for at least 3 months. Anyway, traction devices, we don't have the good ones. So if you done a grafting, you either need to apply a penile splint like this, again, which is well described recently from the same center where I did my fellowship. So it's a penile splint. So what they basically used to do is that the endotracheal tube has a small stillet, a malleable stillet. That same stillet, we used to use it and create a locally a penile splint so that there is no shrinkage of the graft. So the main issue with only grafting is that nearly half of these patients, for example, this study from John Hulal, they said that 46% of the patient had significant reduction in their erectile function after grafting. So in my practice, I either do plication, or if I want to do a grafting, if the curvature is more, I always try to convince the patient for a penile implant plus or minus grafting. I never or hardly do only grafting, because you may give him a straight penis, but it's non-functional. So what's the point of giving him a plaqueless penis, which is not functional? Again, grafting, like I said, ED is quite common, and curvature recurrence, ballooning of the graft, all these are very well described. And if you don't give time in dissecting the neurovascular bundle, even the glans ischemia can happen, which can be seen in up to 2.4%. And that's one of the most dreaded complications to treat. So there has been a recent trend. This paper is published based on the New York database, wherein what this paper noted was that there were 21% of the patients, Peyronie's disease patients, who, even without ED, underwent a penile implant. And there has been significant reduction in the plication and the grafting numbers. The reason being that penile prosthesis is being taken forward as the first line treatment for Peyronie's disease. I'm not saying that everybody who has Peyronie's, you implant him. The thing is, if you're doing any surgical intervention of the penis or a surgical intervention in Peyronie's, please put a penile implant, is what they're trying to say. Same thing we published last year, that I know it's a controversial, it's still an evolving concept. So for example, this patient, anyway, both the pictures are of the same patient. Anyway, that is in the operation theater. So it looks slightly whitish. So such a severe degree curvature could be corrected by just doing a penile implant, and you can do something called as a manual modeling over a penile implant. I will explain that in the subsequent slides. So this paper which we published, we basically said that you can put so penile implant is a good option in Peyronie's disease patients, even without erectile dysfunction, because if you see the long-term follow-up, many patients are unhappy that the penis is shrinking, and then their erections are worsening and so on. So you have one good chance, and try if you can counsel these patients to undergo a penile implant in the first go itself. Again, I'm trying to stress that I'm not saying that you should put penile implants in all Peyronie's patients. I'm trying to say that if you are doing surgery on a Peyronie's disease, try if you can conceive the patient to undergo a penile implant simultaneously. So how do you put a penile implant and also simultaneously correct the curvature? So if you see the guidelines, you first put a penile implant and you feel that there is a more than 30-degree residual curvature. If it is less than 30-degree residual curvature, you don't need any additional maneuvers. These residual curvatures will not cause any much effect. And if it's an inflatable implant, the regular cycling of this inflatable penile implant itself can correct the residual curvatures. So you put an implant, there is still more than 30-degree curvature. You can do something called as a manual modeling. I will explain that. If there is still, even after manual modeling, if there's still a residual curvature, then you can either put few plication sutures, or you can incise the plaque and do the grafting. So this is the manual modeling. So manual modeling is, you can do it over an inflatable implant or also on the semi-rigid implant, but the results are always better if done over a inflatable implant. So you place the inflatable implant and you know these are the corporotomy wounds. So what you need to do is you're basically trying to break the plaque. You're using the rigidity of the penile implant and you are using pressure to break the plaque so that the penis becomes straight. So the few important precautions that you need to take when you're doing a manual modeling is, if it's an inflatable implant, you need to apply the rubber shots for the tubings which goes to the pump. Otherwise, if you apply so much pressure without putting the rubber shots, all that pressure will get transmitted into this pump and then there will be a mechanical failure of this device. So apply the rubber shot, safeguard with 2 fingers the corporotomy wound, and then with the other hand, safeguard the glans. Otherwise, the glans perforation can happen. So with all these precautions, you bend the penis in the opposite direction of the curvature and you bend it and hold it for 90 seconds. Attempt this technique twice. Many a times the curvatures get corrected. And after you have done this, make sure that you inspect the corporotomy wound, so that, because since you have applied so much pressure, sometimes these corporotomy sutures would have given way. If so, take additional sutures and close it. So inspect the wound after the manual modeling. And yeah, so this is again one of the procedures where after doing an inflatable implant and after manual modeling, still there was a lot of residual curvature. So you see, I'm inflating the device. So the penis is fully erect now. I mean, so yeah, it's fully erect, but there is still significant curvature, maybe around 45-50 degree, more than that. So what I did next was, you can do something called as a multiple slit technique, which is a must technique, wherein you do multiple corporotomy sutures ventrally so that the curvature gets corrected to some extent. So the inflatable penile implant is inside, and on top of it, I'm using a cautery. This is completely fine. Just with the inadvertent touch of the cautery device to the penile implant will not cause any damage to the penile implant, unless you have pressed the cautery and held it for 10 seconds on the penile implant only, then it will damage the penile implant. Otherwise, all these inflatable penile implants are very rigid and tough. So you can do this technique. So first is put an implant, try to do the manual modeling, still a lot of curvature. You can put this corporotomy incisions, depending on where the curvature is, put it in the opposite direction, the corporotomy sutures. And then majority of the time, yeah, so you will see some improvements. Yeah, so there is some improvement, but yes, so since it's an inflatable implant, so like I said, we have published also a similar paper stating that even residual curvatures up to 45 degrees, with just the routine cycling of these inflatable implants, these residual curvatures get corrected, because this inflatable implant itself will act as an internal tissue expander, and these residual curvatures get over a period of time gets corrected. So again, so these are some of the operative pictures. Again, 90-degree curvatures corrected with this is semi-rigid implant and the graft. like I said, neurovascular bundle dissection is very critical. And again, this is not one of my patients, the glans necrosis picture. Again, so be careful. Neurovascular bundle dissection is the most critical in the Peyronie's disease surgery. So I have explained to you all the options. So decide your treatment plan based on the current evidence and the local availability, because many of these are the collagenase penile traction devices are not available for us. So surgery remains the main option. And so how I treat my Peyronie's disease patients is that in the acute phase, whether the patient has ED or not, I put them on tadalafil 5 mg daily for 3 months. If the patient says that, doc, because of tadalafil, I'm having a lot of side effects, I'm getting a lot of generalized body ache and all that, then I tell him, take it as an alternate day. So basically something I'll put him on tadalafil for 3 months. And then intermittent, I tell him to take paracetamol whenever on the days he has severe pain. That's all I do in the acute phase. In a stable phase, if the patient has ED, of course, I offer the tablets. If tablets are not helping, of course, self-intracavernosal injection is not a good option in many of these Peyronie's disease patients. Because of the plaque, they find it difficult to inject themselves. So I give the tablet option. If not responding, then I counsel them for the penile implant. And of course, you need to correct the significant curvature in the sense anything more than 30 degree affecting his sexual intercourse. You can offer them plication or plaque incision grafting plus penile implant. And like I said, I never do grafting only. I always combine it with a penile implant if I do grafting. And I don't excise the plaque completely. I basically incise it. And if I see a lot of big chunk of a plaque, I may shave it using the scissor or the knife, but I never excise it completely, because there is a high chance that many of these patients develop permanent ED, or even if I put an implant, this implant aneurysms can happen if you excise a big chunk of these plaques, and it may become, and sometimes these implants may perforate or yeah, through these large defects. So I never excise the complete plaque. So recently this month, we have published a paper on exploring various training opportunities, how the Indian urologist can apply for the andrology fellowships. You can read the latest article of the Indian Journal of Urology. You will get more idea about this. And we continue to publish a lot of papers in andrology. These are the publications in the last maybe 4-5 years. Yeah, so that's all about the Peyronie's disease. I'll be happy to take any questions.
Thank you. Thank you very much. And I really appreciate very scientific presentation. So I will ask quickly questions. If you examine, there are certain hard areas here and there on the, especially dorsum of the penis. You hold 2-3 areas, there will be distantly. One at the base of the penis, another at the middle. They say that both are painful when erection is there, but no curvature. But I'm getting severe pain. So what do you advise?
So wait for 2 years. That is my suggestion. Wait for 2 years. If the patient is repeatedly saying, I know some patients, they come and ask, doc, do something for this plaque because it is causing me pain. I somehow am always hesitant to operate on these patients just for the pain. I always assume that this is an acute phase. Even if the patient has completed 2 years, if still complaining of pain, I somehow try to counsel them that I would not prefer to do surgery on them just for the pain.
We are not aggressive. That's why we were telling the same.
Yeah.
We were telling the wait for 2-3 years also. Second thing is, you are saying incision and then put the graft. Incision will open it adequately to what level you have to incise the depth?
So again, you can, depending on the curvature, sir, when you can incise it. And so, if it's for example, if it's a 90-degree curvature, you need to make a very big incision. Usually we make a H-shaped incision, and then that will give an enough stretch. Again, it comes with experience, sir. Again, usually we cover around 20 degree of the circumference of the penile of the tunica albuginea.
I got the point. Depth, will it go deep up to the corpora cavernosa?
Yes. Yeah. So the entire layer, superficial and deep layer of the tunica albuginea, both have to be incised so that you see the internal smooth muscle.
And
Different people do it differently. Some of them, they incise only the superficial layer and put the graft, but ideally, you need to incise both the layers.
you have to spread a little bit with your both fingers so that it will separate, something like
So
that.
you make a deep incision, you will obviously
Automatically
see
it
this.
separates.
Yeah, it separates, yes.
And do the sutures hold nicely with the plaque?
Yeah, so if there is a plaque, actually it holds better. Of course, you will find it difficult to take the stitches on the plaque. So see if you can slightly trim the plaque, and most of the time you're able to take the stitches.
And if a small plaque excision is, you never told excision of the plaque in the entire talk. That
I
means
only
it is very important that you may create a weakness in the tube, which is not good for the erection in the future.
yeah. If it's very prominent, I know patients will be unhappy if I leave it behind. I just scrape it with the scissor to some extent, or may shave a bit of it, but I never remove it completely.
Circumcise and remove it.
Yeah, no, I don't do
That's
it.
not correct.
Because this is what I've learned from my mentors, and I'm
back I
continuing to
heard
do
that
this.
you can put a patch, and
Yeah.
then that will. But you told that future the aneurysm of the penile shaft can come, and also you told that bulging also, erectile dysfunction also can occur.
Yes, sir.
Like
Yeah.
you said.
So I never do only grafting, sir. If I'm doing grafting, I convince for a penile implant also simultaneously.
Okay. Most of them will have some ED also.
Yeah. And over a period of time, all these patients will develop ED. So I would always give it one chance. You do a good surgery and patients will be happy. Initially, they will say that because of the cost issues, no, we cannot afford an implant and all that. But when you spend some time and counsel, most of them will agree. But like I said, only 2% of these patients agree for surgery in Peyronie's disease.
In penile fracture, we do nicely with prolin, inverting sutures, and most of them have good direction. But do you think that if partially improperly sutured penile fractures or untreated penile fractures can cause these type of fibrous tissues? Any that question I am asking.
Yeah, I know, sir. So penile fracture, what happens is when the fracture happened, I mean, after a few months, if there is a corporal fibrosis, only then they develop erectile dysfunction. If it is just a scarring alone, they will usually not develop erectile dysfunction. Again, untreated ones, if it's a big tear, anyway, they will have lot of hematoma. They will usually end up surgery done. But if there is a corporal fibrosis in the smooth muscle area, that inside that, if they have a fibrosis, only then develop erectile dysfunction.
And what about the age distribution of the Peyronie's disease? Have you ever seen very severe Peyronie's disease in less than 30 years before their marriage?
No, before their marriage, I've never seen, sir. They come with curvatures, but it's not Peyronie's. It's usually a congenital penile curvature. They come now because, yeah.
Some people say woman on top causes micro trauma and can cause more Peyronie's disease.
Yeah. One of the theories, yes, it is described, sir, but again, like I said, the etiology is completely unknown. Yes, one of the theories is so.
If somebody is masturbating and if his penis is directed towards the left, if you say masturbate for right for 2-3 years before marriage, do you think that gets corrected?
I think you're talking about the penile traction therapy
No,
concept.
I'm talking about penile curvature without Peyronie's.
Yeah, I know, sir. But no, that is not going to work, sir. Because because all these traction or the forceful therapies that have been described, they work on the abnormal things.
2 years if they masturbate with opposite hand.
Yeah.
I mean, I don't know.
There is no evidence, sir. I mean, I have never used this. This is the first time that you're giving me.
Basically, like traction therapy. And if you have closer to urethra, any plaque or something, do you take any extra precaution? Mostly lateral, very close to urethra if fibrosis is there. Anyway, you are incising, you are not going to touch the urethra and separate it, na?
No, sometimes you'll have to elevate the urethra, sir. If it is a dorsal, if it's a ventral curvature, sometimes you'll have to elevate depending on where the plaque is, sometimes you may have to mobilize the urethra completely.
Urethra also.
Yeah.
And what are the tips and tricks to see? What are the tips and tricks to elevate the neurovascular bundle? For example, I want precisely 3 points. How lateral first incision to be given? How deep the incision should be given? What instruments to dissect the tissue? and how to lift them. 4 questions.
Okay. So the one is, you start from the paraurethral region. So you know the urethra, this thing, maybe just 2 millimeters, you can put an 2 millimeters lateral, put a vertical incision. First make a 1 centimeter incision, and then try to make a space. You basically have to reach the tunica albuginea layer.
That is a crux.
Yes, sir. Paraurethral, tunica albuginea, and when you're dissecting slowly, your assistant should not hold with the neurovascular bundle. You don't hold with any tooth forceps. Try to use it with the Babcock's, or best is hold a mop and then get hold of this neurovascular bundle. And slowly you need to move it. And then near the more closer to the glands, you need to leave a lot of tissue. Do not dissect very close to the glands, because that is when the high incidence of glands ischemia can happen.
I think nerves will be coming entire penis and glands. If you are lifting so much into the air, won't the main shaft nerves and vessels will get affected?
So the shaft,
if you are lifting in the air like this.
Yeah, the shaft blood vessels, the cavernosal artery will take care, and also the ventrally, the bulbo cavernous artery will be there. So that will take care of that, sir. So if you're doing,
I'm asking the nerves part. Nerves also will be.
Yes, sir. So the nerves, again, it will be in the neurovascular bundle. It will go into the glands, sir. So in the corpora cavernosa, there is not much of a sensation there in that. Most nerves, basically, they go and land up in the glands.
So you go paraurethral and lift entire tissue.
Yes, entire tissue, yes.
That means almost 270 degrees you are lifting the tissue.
Yes, sir. Full entire you need to lift. Sometimes with just one side only, you can go and reach the opposite side. If it is difficult, then
the
both
plane is very good. You can just slightly lift it like
yes.
Whatever you do, it should be done below that. And is it easy to retract without traction on the neurovascular bundle? Because when you lift it, you don't have space to go in the center of the penis. That may be difficult.
Some traction has to be given, sir. And then try not to use any cautery there. Even if something bleeds, try to take a small, maybe a 4-0 or a 5-0, and then stitch it. Don't use cautery at that place.
Vessel loop and magnification you will use?
Yes, sir. I use magnet loop. I use the loop. I use 2.5x.
2.5x. Very nice. So a lot of appreciation. Splendid lecture. Excellent lecture. Very informative. They have come. Thank you very much. And you are a very crisp speaker, I must tell you, because I interact with hundreds of people. You have command because you have written papers and you are very much interested. I wish you should do very well in the Urology of Urology Society of India. Thank you very much.
Thank you, sir. I usually don't like to tell stories, so I try to say the points upfront.
Good. Very nicely you told. Very nice.